Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. Today's episode is on weight gain in ART, featuring Dr. Joseph Eron from University of North Carolina. He'll take us through a case study of a person with HIV starting therapy, and he'll explore if and how he considers the potential for weight gain when choosing among treatment. This episode is taken from our series on key decisions in HIV care. You can follow along with the slides, which are available in the show notes. So let's get started and listen in to Dr. Eron.
Hi, I'm Joe Eron. I'm a professor of medicine and epidemiology at the University of North Carolina. And I'd like to welcome you to our program, Key Decisions in HIV, Weight Gain with Initial Therapy. So what we're going to do is start out with a question, a CME question, which I'll read to you and you can look at, and then we'll go to a case, and then I'll give you some what I think are important teaching points, and this all should take 5 or 10 minutes. So the pre-survey question is, which of the following initial regimens is associated with the least amount of weight gain? So that's our question. You can go ahead and vote on that. And here's our case. So he's a 35-year-old man, recently diagnosed with HIV after presenting with secondary syphilis. He's actually on no medications, but he does have a very strong family history of type 2 diabetes. A brother, a mother, and 2 maternal aunts all have type 2 diabetes. He has sex with men, and he has 3 regular partners. He thought that he was in a stable relationship with these partners, but obviously syphilis got introduced at some point. He's an accountant, and because of the risk to his partners, he's very, very interested in starting therapy. His baseline characteristics are on the right. He has a good CD4 cell count, suggesting relatively recent infection. His viral load is greater than 10,000, but not very high, 15,700. He does have a pre-therapy resistance mutations, K103N. He's immune to hepatitis B. His hepatitis C and A status are negative. He has a serum creatinine that is normal for a man. His AST and ALT are slightly elevated, which may suggest that he has some fatty infiltration of his liver as one possibility. His CBC is normal. His cholesterol is elevated, and he's obese with a BMI of 34. And his A1C, while not diagnostic of diabetes, it suggests glucose intolerance. So he's already at risk for diabetes. What do we know about weight gain following initiation of therapy? And I'm going to talk specifically about initiation of therapy, and I'm going to go quickly, but there's some points here. If you go from left to right, this is from a study published in Clinical Infectious Disease by Paul Sachs and a group of colleagues. It shows that when people start therapy, they're more likely to gain weight, more substantial weight on an integrase-based therapy. The second thing that I get asked all the time is whether there's a difference between bictegravir and dolutegravir. And I think the data in the center show very clearly that there really is no difference in weight gain between bictegravir and dolutegravir. And these are data from randomized comparative studies. So I think these data are quite strong. Elbictegravir cobicistat, which is no longer recommended in our guidelines, is associated with less weight gain. And then all the way to the right, you see the differences related to the nucleosides. And not surprising, zidovudine is at the bottom. It's associated actually not with any weight gain. And TAF, tenofovir alafenamide, is associated with the most weight gain. And this is a little hard to tease out, but we hear a lot about the association of TAF with weight gain. Abacavir is somewhat less, and TDF is associated with a very modest amount of weight gain. Again, this is from a series of randomized trials that were conducted by a single sponsor. And this next slide shows ADVANCE. It was a randomized trial in South Africa, and it compared 3 regimens, dolutegravir TAF FTC, dolutegravir TDF FTC, and efavirenz TDF FTC. And what I'm showing here is weight gain over 96 weeks divided between men and women. Virtually all the individuals on the study were Black African people. And you can see a couple of things. One is that the red line, efavirenz FTC TDF, is associated with very little weight gain. which is a bit surprising because these are people starting on therapy, and there should be some weight gain associated with return to health. So that's a suggestion that efavirenz and perhaps TDF is actually are weight suppressants, or they mitigate against weight gain. And there are other data to support this, actually. And then if you look between dolutegravir FTC TAF and dolutegravir FTC TDF, you can see that the dolutegravir with TAF has the greatest amount of weight gain, not significantly different in men, but really quite different in women, with an average 10 kilogram weight gain. And that's a mean weight change, 10 kilograms. That's easy to calculate. That's 22 pounds. That's on average. So clearly this raised the question about associations of second generation integrase, dolutegravir, and TAF with weight gain. What kind of risk might this have? So this is a modeling study that was done using those advanced data in people on the advanced study that were greater than 30 years of age. And it looks at the risk, the estimated risk. So these people didn't develop cardiovascular disease or diabetes, but it looked at the estimated risk based on weight change and also change in lipids and change in some other laboratory results, the estimated risk associated with the various regimens. And there was a very modest increased risk with dolutegravir FTC TAF for cardiovascular risk, probably related to cholesterol, that authors didn't digest that completely for us or break it down for us. But if you look at on the right, the estimated 10-year risk of diabetes was actually highest with dolutegravir FTC TAF, and actually, interestingly, lowest with dolutegravir FTC TDF. And these numbers are a little hard to interpret, but basically there's a 0.7% greater risk, or 7 people out of 1,000 that would develop diabetes when you compare dolutegravir FTC TAF with dolutegravir FTC TDF. So greater estimated risk of diabetes. And the other thing that we know is that people with HIV who go on to therapy gain weight. And it turns out all of us, or on average, most of us gain weight, whether we have HIV or not. But the one thing that's different in people with HIV that are different than people who are not infected is that even people who are obese at baseline, so if you look all the way to the right on this slide, you can see that people who are obese continue to gain weight if they have HIV compared to people who don't have HIV, whose weight essentially remains stable over time. And this is over years. This is from a very large Kaiser database. Using these data, and then finally, the one question that comes up is, well, maybe if you get rid of TAF, that would be the best result of all in terms of limiting weight gain. And I think the best data to address that question are the GEMINI data. GEMINI was a study of initial therapy that compared dolutegravir 3TC versus dolutegravir FTC TDF. So one regimen has no tenofovir, so no TAF, and the other regimen has TDF. And I think if you'd asked me initially, I would have said, well, they'll have about the same weight gain. That wasn't the case. As you can see highlighted in the middle of the slide, those individuals that were on dolutegravir FTC TDF actually had less weight gain. So if we go back to the ADVANCE study and other studies that have an impact, for example, it looks like TDF actually mitigates weight gain. We don't know the mechanism, but there probably is some effect of TDF on weight gain. So now we look at our guidelines, and the regimens that I would consider for this gentleman are all in our guidelines. Our guidelines are in pretty good agreement. The IAS-USA guidelines do not recommend abacavir. They do not recommend raltegravir, but both guidelines do recommend dolutegravir with either FTC and TAF or TDF, or dolutegravir with 3TC though there are caveats for that. You have to have a lower viral load and also be immune to hepatitis B, or you can't have active hepatitis B. Summing up all that information, we go back to our gentleman. He's obviously at very high risk of diabetes. He has a very strong family history of type 2 diabetes, so he's genetically predisposed. He's obese already, and he has an A1C in a range that would suggest that he's already glucose intolerant. So what regimen would I start in this man? And I think I think my choices are, I have not changed my practice. I still use either dolutegravir or bictegravir as I would for initial therapy. I can't even think of a common presentation where I wouldn't use either dolutegravir or bictegravir. But in this man, I actually would consider a TDF-based regimen. And I think my logic here with dolutegravir TDF-FTC would be that would limit his risk of weight gain over the first period when he starts therapy. And there are obviously metabolic changes associated with treating HIV. And that might limit his short-term risk for diabetes. And it may also give me time to work with the patient on weight loss strategies, treatment for prediabetes, which now we have some, and there are treatments now for weight loss, and then potentially then move to a regimen such as dolutegravir 3TC that may be safer over the very long term. So that's my clinical decision making, and that's how I would think through this particular case. So we go back to our pre-survey question: which of the following initial regimens is associated with the least amount of weight gain? And hopefully, as I've explained through our discussion, dolutegravir TDF-FTC is actually associated with the least amount of weight gain of the regimens listed. Many people may have thought about dolutegravir 3TC, but we know from the GEMINI study that dolutegravir 3TC does lead to significantly more weight gain, a modest amount, but significantly more weight gain than dolutegravir TDF-FTC. So thank you for your time. I appreciate you sticking with me for these few minutes. Here are our take-home points. We know that weight gain is very common after the start of ART. Some of that weight gain is good, right? Some of that is return to health. Weight gain occurs in those people with HIV, even if they're overweight or obese. So that's an important point. So we have to talk to our patients and warn them. They're still at risk of weight gain. We know that weight gain is greatest with second-generation integrase inhibitors, and by that I mean bictegravir and dolutegravir. Weight gain with TAF-based therapy is greater than weight gain with TDF-based therapy if the other components are similar. And agents like TDF or efavirenz may actually suppress weight gain. But when making your decisions, we have to consider the ability of the regimen to suppress HIV, tolerability for the patient and safety, and also convenience, or what fits best into a patient's life, remain the most important factors when starting ART. So once again, I want to thank you for joining me. You may know that CCO has many additional online activities for key decisions in HIV care. We have the Medical Minute and podcasts. We have these clinical thought commentaries from both physicians and patients. And there are patient education sheets that you can print and share. So thank you for your time.
Thank you, Dr. Eron, and thanks to you, the listener. To listen to more episodes in this series and to see slides and webcasts on key decisions in HIV care, see the links in the show notes. Thank you, and we'll see you on the next podcast.